Hello everybody and welcome to the cardiovascular section. Now the physical finding flashcards are a unique endeavor. They are the endeavor to have you learn all the heart sounds, breath sounds, bowel sounds, skin findings that you will see on step 1 of USMLE. And to make sure that you can remember it, we're going to show you roughly 5 times more images that are in the physical finding flashcards that you can get from a bookstore or from Amazon or any form of bookseller. We're going to make sure that this experience adds on all of the pathology of the skin findings. So you'll be shown all the microscopics. It's going to show you the physiology of the cardiovascular section. It will show you the microbiology of the infectious disease findings, and we'll make sure that the video endeavor, this tool right now, adds on everything for step 1. The box will have everything on step 2 and 3 on it, but step 1 is harder because just like this video, it adds on the histology and all of the basic science that you need to do well on your test. In addition, it is exciting. Cardiovascular, let's jump right in. The Allen test. We don't like tests that are named after people because we have to retranslate that. Is there an Allen test? There's John test, Thomas test, Sarah test. An Allen test, when is this test done? How is it done? And the other part is simply when is it indicated? Well, the Allen test is a test that is done to make sure that the circulation in the hand of a person is adequate. It's a hand circulation test. Now, as recently as this week, I saw a patient that had insufficient circulation of the radial artery. And when they put a vascular device into one of the other arteries, it actually necrosed the hand because the patient needed an Allen test to test the circulation of both sides of the hand. So what you do is you occlude both arteries, both the ulnar and the radial artery, and what you make sure is that the hand becomes raised, so you empty it of blood and let it turn pale. Then when you release one side, you're releasing only one side of it, what happens is that you'll be able to see, does the ulnar artery have enough capacity to perfuse the whole hand? So this is a test of saying, is the ulnar artery sufficient to be able to perfuse that hand? And you look to see for the flush that develops. Now, an Allen test is done basically to see, can I put an arterial line in? The basic science answer is to say, what is the mechanism? It looks to see ulnar artery perfusion. And it assesses whether there's an ulnar artery that's sufficient to perfuse the whole hand. If the ulnar artery is sufficient, then what will happen is that the hand will turn red when you release the ulnar side, showing perfusion, and it avoids the damage of necrosis. What we see here is a picture of the Allen test. On the left-hand side of the picture, we're occluding both the radial, and the ulnar. Radial and the ulnar, occluding both of them. And then what we're doing is we're going to release one side and see, does the hand stay perfused by just releasing the ulnar artery. That's how you test vascular flow. It also is an anatomy question, isn't it? It shows you this arc of vessels between the radial and the ulnar artery. That's an artery flowing into another artery. Kind of interesting, isn't it? Yes, it is. And this is a picture of the occlusion of the ulnar artery, showing decreased perfusion of the hand. There shows that the predominant distribution of the radial artery is 1/2 of the hand with the thumb on it. Here we go. You're occluding both sides. Occluding both sides. We're juicing out, milking out the hand of all the blood so that it will turn pale. It is the pallor that allows us to see whether the perfusion is happening. Now you're going to see a release of one side after the pallor and see whether or not, whoosh! Wow, look at that red hand. Isn't that amazing? It's like post-masturbation here. Okay, and we have the red hand here showing you that that hand can be fully perfused by the ulnar artery, and this means that the radial artery is fully intact. That's the Allen test. Now, next one, the ankle brachial index. You might say, why are we starting with ankle Allen test and ankle brachial index? And that is the bright answer called publishing, putting these in alphabetical order. Very good. Alphabetical. How interesting. Ankle brachial index. First of all, what is it? Ankle brachial index. I think it has to do with the ankles and the brachials. Yes, it's a blood pressure test. What disease does it look for? Ooh, it looks at the difference in the blood pressure between the ankles and the arms, and the ankles and the arms. The most accurate test of any vascular structure is always an angiogram, an arteriogram. The ankle brachial index measures the blood pressure difference between the arms and the ankles. What should normally be greater? The blood pressure in the arms or the blood pressure in the ankles? And the answer is the ankles, particularly when standing. When I'm standing up like I am now, my blood pressure for me, because I'm a fairly tall guy, is about 60 to 80 millimeters more than it is in my arms because of gravity. When you're lying flat, they should be about equal. And standing up, ankles should be greater. But at no point ever in a normal person should the blood pressure be greater in your arms. This is a very common misunderstanding because the average student says, wait a second, isn't this close to my heart? Isn't the blood pressure going to be greater there? Very natural, logical, wrong answer. Even though it's physically close to your arm, it is in fact based on gravity. That's right. That's why toilets flush down. They don't flush up. Gravity. So they should be within 10% of each other because 10% is sort of the standard of the measurement difference. Now, remember that these cards are meant to be able to have you do well on clinical rotations when you become a third-year student. Because remember, the day after you finish Step 1 or Complex 1, the day after you finish that, you're going to become a third-year student and you're going to be on rounds and your attending is going to ask you these. But the Step 1 question also says, what's the mechanism? What I just said, gravity. So the ankle blood pressure should be at least equal when you're lying flat. So therefore, ankle brachial index is a very important answer to the question, what is the best initial test of peripheral arterial disease? And the word peripheral arterial disease is a better answer than peripheral vascular disease because peripheral vascular disease could imply the veins. But peripheral arterial disease is where the insufficiency really is. So a severe abnormality is a lower ratio. In other words, when the ankles are really much lower, implies greater obstruction. The most accurate test of any vascular structure is always the angiogram. What does it look like? It looks simply like, and here's one great thing, is that if you're a fast student, pause and read. If you're a slow student, you can go over 57 times as much as you want. You're looking at the blood pressure between the arms and the ankles to see which one is greater, to see if there's an obstruction. That obstruction makes the blood pressure in the ankles much lower, decreasing the flow. Remember, aspirin and cilostazol, statins. And what's the best blood pressure medication for peripheral arterial disease? The best blood pressure medication in peripheral arterial disease is an ACE inhibitor. Bonus question, bonus point is, do calcium channel blockers help in that? Do calcium channel blockers help in that? And the answer is no, they do not. Calcium channel blockers do not help because this is not a vasospastic problem. You'll look at the difference between the blood pressure between the arms and in the legs. Our next question. Let's listen. So in this person, if we tell you this is heard over the heart, it depends on which area of the heart. If it's heard at the lower left sternal border, it is diastolic decrescendo. And a diastolic, lub, 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 and that diastolic decrescendo murmur is aortic regurgitation or aortic insufficiency. There is no fundamental difference between aortic insufficiency and aortic regurgitation. They both mean about the same thing. Aortic stenosis would be if the question said that this was a systolic sound. Because I'm telling you that it's a diastolic sound, that's what makes it aortic regurgitation. Now, this is best heard over the lower left sternal border. The most common cause of aortic regurgitation, is insufficiency of the aortic valve. It is a floppy, loose valve with a dilated aortic root. It is things like hypertension, stretch the heart. Marfan, stretch the heart. Syphilis, stretch the heart, stretch the heart. Now, anything that stretches the heart, like hypertension, that's by far the most common. Dilated cardiomyopathy will do it and dilates the aortic disease. Hand grip. Ooh, what's the hemodynamic effect of hand grip? Squeeze, 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 squeeze. The hemodynamic effect of hand grip on the heart is to increase afterload. Okay, to increase afterload. Valsalva prevents venous return to the heart, and squatting and amyl nitrate. Squatting increases venous return to the heart. Amyl nitrate is a vasodilator. Amyl nitrate is the opposite of hand grip. Amyl nitrate decreases afterload. Now, the other findings on the exam, aortic regurgitation is loaded with all sorts of extra findings on exam. Now, at the beginning, if you got this on the third time, you should feel terrific, because to understand the auscultatory maneuvers is hard at the beginning, but it's going to be made easier. Aortic regurgitation is a diastolic decrescendo murmur, and it is heard at the lower left sternal border, and that means, and also it should radiate down, okay, should go radiating down, because what it does is it follows the aorta like a horn, follows that aorta, and it's most often secondary to things that dilate the aortic root, like hypertension, Marfan's, Ehlers-Danlos Syndrome. Ooh, remember Ehlers-Danlos Syndrome? I feel so stretchy. I'm stretchy. It's like living in a yoga. It's like living in Bikram Yoga Center, like living there in stretchiness. And Marfan's dilates things. And Reiter's syndrome is a reactive arthritis with HLA-B27. This is the HLA-B27 things. Endocarditis does it because endocarditis causes vascular insufficiency and dilates the aortic root. All of these things are different ways of saying, do you know what dilates the aortic root? Hand grip increases afterload. Hand grip pushes blood backwards. Hand grip contracts the arteries of the arm, smushes the arteries of the arm. Hand grip squishes the arteries of the arm and compresses those arteries so that it makes it harder for blood to get out of the heart. So hand grip is the opposite of an ACE inhibitor. If you treat regurgitation with ACE inhibitor, hand grip makes it worse. If you treat it with ACE, vasodilator, hand grip makes it worse, because hand grip squeezes those arteries. If it gets better with an ACE inhibitor, it'll get better, improve, softer with amyl nitrate, because amyl nitrate dilates the vasculature. Amyl nitrate dilates the vasculature and makes it easier for blood to get out of the heart. Valsalva, we get that? Amyl nitrate is a vasodilator, an arterial and venous vasodilator. So it decreases afterload. That's the major thing. Its effect is the opposite of hand grip. Hand grip squeezes the arteries. Amyl nitrate relájate, suave, raslapsia to arteries. And Valsalva decreases venous return. Now, knowing the mechanisms of these auscultatory maneuvers is considered indispensable for all three steps of USMLE and complex. It's considered indispensable for all three steps of USMLE and complex, because even though we almost never do it clinically, it means you understand the murmurs. And that's what step 1 is about. Do you understand the mechanism of the murmurs? Even if you don't actually do it, do you know how to do it? Squatting does the opposite of Valsalva. Squatting increases venous return by squeezing the leg veins. Squatting squeezes the leg veins. Squatting squeezes the leg veins. And what squatting does is increase venous return to the heart because it squeezes your thighs. Don't your thighs have a lot of volume? If we squeeze them, your heart is filled. So aortic regurgitation or insufficiency also gives a high bounding pulse because the heart knows that it's insufficient and a lot of the blood in those blood vessels is going to regurgitate backwards. So what happens is that the blood shoots up only to splash half back. It shoots up only to splash half back. And that's why aortic regurgitation gives a huge high pulse, sometimes also called a water hammer or Corrigan's pulse, and then it rapidly diminishes. De-Musset's sign, man, can you imagine like that? What it must be like to be De-Musset? What did you do? I got my name on a side that's head bobbing. Yeah, well, De-Musset actually was a French playwright and a poet from the some 19th century French playwright and poet who had aortic regurgitation. It's actually not a doctor. It's named after a guy who actually had it. And it's the head bobbing that goes with the high bounding to pulse. Hi, how are you? What do you have? I got aortic regurgitation. Oh yeah. De-Musset. Got the aortic regurg now. And that's De-Musset's sign. And also has a lot of other odd things that don't happen in any other disease. Pistol shot pulses are heard over the femoral arteries. And de Rossi has a sign. I know. Isn't it terrible? You have to memorize all these things. But you know, we really want you to know this about bruits and thrills and bruits. And these are basically diastolic murmurs. Basically, this is a sign of extremely high rapid flow that can be heard in your femoral arteries. Now, a Quinky pulse, which we're going to show you later on, you're going to see a Quinky pulse. A Quinky pulse is a sign of pulsations in the nail beds. A sign of pulsations in the nail beds from vascular flow. That's a Quinky pulse. Vascular pulsations. Now this is showing you one of my favorite basic science step 1 laws. And one of Dr. Fisher's favorite basic science step 1 laws is the law of Laplace, the law of the place. And the law of Laplace says that as things widen, the wider things are, the greater the tension in the walls. The wall tension, the wider the something is, the greater the radius across, the wider the radius, the wider it is, the more the wall tension. And this wall tension is a tension that's trying to pull apart the wall, trying to stretch the wall, yank the wall, widen the wall, pull it apart. And the wider it is, the more wall tension there is, pulling apart that blood vessels. So wider things, as the radius goes up, in order to maintain that pressure the same, the wall tension rises. In order to keep the pressure the same, the wall tension rises. And that's why, as the radius goes up, simple question, as the radius goes up, another way of saying it is wall tension, and that means wider things widen even faster. That when balloons blow up, they blow up even faster at the end. Small balloons are hard to inflate. Big balloons are easy to inflate because wide dilates and narrow collapses. That's why when people get dilated aortas and when they get dilated hearts, they tend to dilate faster and faster and faster and faster, and then you die. Everybody who has dilation automatically has regurgitation. Everybody who has dilation automatically has regurgitation Because as the heart stretches up in size, what happens to the size of those leaflets? What happens to the size of the leaflets as the heart stretches up in size? As the heart stretches up in size, do the leaflets increase in size? The answer is no. As the heart dilates up, the leaflets stay the same. So therefore, as the heart dilates up in size, as if the leaflets stay the same size, if the leaflets stay the same size, it means there has to be regurgitation. Because dilation with leaflets staying the same size means regurgitation because they separate. When your ass gets big, does your underwear change in size? The answer is no. As your ass gets big, the underwear has to separate off. It doesn't cover as much. And that's why the leaflets. Wider things get bigger faster. Wider things dilate. Wider things dilate. Smaller things collapse. Wide blood vessels continue to get aneurysmal. Smaller blood vessels don't get aneurysmal. If this is the airway, because what we're representing here is airways, the same thing of the law of Laplace is true. Small collapses, large dilates. Small is easier to collapse, but as you regurgitate and you get wider, this will happen and get wider and wider and wider. This is why in aortic stenosis, by the time you get congestive heart failure in aortic stenosis, by the time you get congestive failure, you're going to be dead in 1 year to 18 months. Dead in 18 months. Worse than metastatic cancer is a dilated cardiomyopathy. Dilated cardiomyopathy dilates faster. When you get dilated even more, you explode. Now, one of these is small and one of these is large. Which one of these will expand? Let's go back to our law of Laplace. We said small collapses, large expands. And this is the law of Laplace again. Small collapses, wide expands. So if we're looking at these balloons, which of these has greater wall tension? Small yellow or big blue? Oh, what we see here is that the wider balloon dilated, the smaller one collapsed. Because isn't it interesting? Even though there was more air in there, it was under less pressure. And it caused the wall tension in this one is less than this wall tension. That wall tension is greater, and therefore it squeezed the air into the bigger one. Wow, I keep watching that day in and day out. What do we hear? Oh, a diamond-shaped systolic murmur, crescendo, decrescendo. Crescendo, decrescendo, diamond-shaped systolic murmur, and that is aortic stenosis. The second right intercostal space, aortic stenosis. Crescendo, decrescendo, aortic stenosis. Now there is one other thing that has this diamond shape, and that's hypertrophic obstructive cardiomyopathy, HOCM. Now HOCM is an absolute must-know subject for step 1. We love HOCM. We love those basketball players going dribble, 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 shoot, score, die. Sudden death. Yes, it does cause sudden death in healthy young athletes. That's true. But most people with hypertrophic obstructive cardiomyopathy, what's the most common presentation? That is a great question. HOCM, most common presentation of HOCM is not sudden death. It's not syncope. It's good old-fashioned shortness of breath. So HOCM presents with shortness of breath. So one of the ways that you can tell apart aortic stenosis from HOCM is HOCM presents with a sudden death, but not as much as it does with shortness of breath. Okay, now the most common symptom of aortic stenosis, HOCM, is shortness of breath. The most common symptom of aortic stenosis, it's actually angina, chest pain. That's the most common. And it radiates, aortic stenosis radiates to the carotids. It radiates up to the carotids. And now, oh, look at this. We're already repeating. We've only been together for a few minutes. We haven't even been together for 20 minutes. And already we're repeating. Isn't that fantastic? It's like a boring relationship. I've known you for 20 minutes and you use that same joke 3 times. You're boring. So aortic stenosis, hand grip, the effect of hand grip, squeeze the arteries of the arm, increases afterload. Now, Valsalva decreases venous return to the heart, because when you decrease venous return to the heart. Squatting does the opposite of Valsalva. Valsalva and squatting are the opposite of each other. If Valsalva decreases venous return, decreases Valsalva venous return by increasing intrathoracic pressure. Squatting increases venous return. Squatting increases venous return. Now, the therapy for aortic stenosis, there's no medical therapy. No medicines, not for aortic stenosis. Now this is aortic stenosis, crescendo, decrescendo. It's heard at the second right intercostal space, and it goes up into the carotids. The most common presentation is angina, chest pain, and the worst, the one that means you're going to die the soonest, is congestive failure. Now why is angina the most common presentation? Is because 2/3 of people with aortic stenosis have coronary disease. 2/3 of people with aortic stenosis have coronary disease, so they have a greater problem already. Their coronaries are diseased, and therefore they can't deliver blood. Number 2, does the person with aortic stenosis have an atrophic ventricle or hypertrophic? Atrophic or hypertrophic? Aortic stenosis is associated with a hypertrophic cardiomyopathy. Aortic stenosis makes the left ventricle big and thicker, because it's going, yeah, I get to go big and macho, and it gets bigger, so you have an increased demand. So aortic stenosis has a decreased supply with an increased demand. Aortic stenosis has a decreased supply because the coronaries are narrow with an increased demand. The other thing is, the aortic valve is right in front of the coronary ostia. Anatomy question. Where do the coronary arteries start? Coronary ostia. Coronary ostia, and the coronary ostia are just distal to the aortic valve. So you're blocking flow into my valve, man. The worst is congestive failure because you've dilated the heart. Once the heart dilates up in size, what can you do to restore it to normal size and shape? Once the heart dilates up in size, what can you do to restore it to normal size and shape? Nothing. Once the heart dilates up in size and you get a dilated cardiomyopathy, all you can do is transplant it. Do you know that we don't have a therapeutic way to shrink hearts? So you die instead. Now, the basic thing is that aortic stenosis radiates to the carotid, mitral regurg radiates to the axilla. Aortic to the carotid, mitral valve go to the axilla. Hand grip increases afterload. Because hand grip increases afterload, does it make it easier for blood to leave the heart or harder for blood to leave the heart if you increase afterload? If you increased afterload, it makes it harder for blood to leave the heart, and therefore hand grip softens the murmur because it makes it harder for blood to leave the heart. Aortic stenosis is decreased because it makes it harder for blood because the pressure goes up in the arteries. The pressure goes up in the aorta. Now, Valsalva decreases the murmur, because anything that decreases venous return decreases left-sided murmurs for almost all of them. Valsalva decreases aortic regurg, decreases mitral regurg, decreases aortic stenosis, decreases mitral stenosis. Valsalva, less blood in the heart. Less blood in the heart, less murmur. Less blood in the heart, less murmur, softer murmur. Like the difference between this and this. More blood, more murmur, less blood, less murmur. For everything, in fact, except mitral valve prolapse and HOCM. Mitral valve prolapse and HOCM do the opposite of all of those. Now, these cards are useful as one item just to be able to get all the murmurs. Valsalva decreases venous return, and standing suddenly decreases venous return. Valsalva means less blood in the heart, and standing means less blood in the heart. And basically what this means, it decreases preload. Squatting increases preload. Leg raise increases preload. Squatting increases venous return. Leg raise, lifting your legs in the air, increases venous return. So squatting and leg raise, more blood, more murmur. More blood and more murmur, and they increase. More blood, more murmur for everything except mitral valve prolapse and HOCM, which go the opposite. Aortic stenosis, there is no medical therapy. You basically have to replace the valve. You have to replace aortics and remove balloon mitrals. Replace aortics and balloon the mitral valves when they're stenotic. You can't balloon in an aortic. Why not? I want to balloon in the aortic. You never let me balloon in the aortic. Daddy, Daddy, I want an Oompa Loompa. I want to balloon the aortic. And you can't balloon the aortics because of the pathology. The pathology of aortic stenosis is that in aortic stenosis, you have it from calcification. Bony, rocky, hard. And you can't balloon bony, calcified, rocky, hard things. You can only balloon fibrosis. We balloon the valves, that is mitral stenosis, because mitral stenosis is fibrotic, because mitral stenosis is from rheumatic fever. So you can balloon the mitral and replace the aorta in stenotic lesions. Now here is a sign of the stenotic valve. This is the normal pressure in the left atrium. Not much, 5 or 10, very small. If you're standing up, it's actually subatmospheric. Lying flat, it's about 5 or 10, very small. And basically the systolic blood pressure is 120. You notice that the systolic pressure in the aorta, is 120, with the systolic pressure in the aorta in the ventricle. You notice how that's the same number, 120, 120? Well, there's a reason for that. The systolic pressure in the ventricle and the aorta should be the same, because the systolic pressure in the aorta is the same because there should be no barrier. Because there should be no barrier to the flow of blood up into the aorta. There should be no barrier to the flow of blood up into the aorta, because it should be fully open. Now this stenotic valve, do you see the red thing? That's the aortic stenosis. That stenotic valve there, you see how the pressure here is 200? See 200? Really high? 200? Squeeze me! But the pressure there is only 110. How come the pressure there is so much lower? How come it's so much lower? The answer is that there's a gradient because all the backflow. The stenotic valve makes this pressure higher, and also the left ventricle is thicker. The left ventricle is thicker. So that's a valve gradient. So that is a valve gradient, because when you have a blood pressure that's much greater here than there, because this is the valve gradient, and this is the single greatest measure. What's the difference in blood pressure between the left ventricle and the aorta? That valve gradient means difference. Valve gradient means difference. So when you have that valve gradient being really different, it means you got a sicker heart. The greater the gradient, the worse the heart. The greater the gradient, the sicker you are. The greater the gradient, the worse the heart. Replace you're gonna die. I'm gonna die. I'm gonna die. Oh, my gradient's really high now. My gradient's really high now. My gradient really high now because I'm gonna die. I know, like your mother has aortic stenosis and I just made fun of it. Well, it's better to laugh than to cry, you know what I mean? Why do angels fly? Because they take themselves lightly. Now, this is a graphical representation, okay? This is a graphical representation of aortic stenosis. This is a graphical representation of aortic stenosis because this shows you the gradient. This is the aortic pressure, the green line, aortic pressure. Why is the aortic pressure so much lower than the left ventricular pressure? Left ventricular pressure, aortic pressure. Why is the gradient, okay, why is the difference there? Because there's a stenotic valve in the way. So this, look, 200, 110. So, 200, 110. So this is a representation of that valve gradient. The aortic pressure is so much lower than that left ventricular pressure because there's a stenotic valve in the way. And the more that difference, the greater the gradient, the greater you need to be able to have that valve taken out. Now, if less blood is going through a stenotic valve, how come, as you have a worsening aortic stenosis, how come there's more noise? This is a very thing. You see, most people say, they go, yeah, sure, stenotic vessel, narrowed vessel, makes noise. Well, is flow greater or is flow lesser in a person who has aortic stenosis? Flow is lesser. Well, if flow is down, how come it's louder? Wouldn't normally things be softer and quieter if there's less flow? Well, here's where physiology comes to the rescue with an explanation. So our next basic science physiologic point, and remember the flashcards, the ones in the box are really set up just for step 2 and 3. The video has the step 2 and 3 end and adds the step 1 end on it too. Because the step 1 end says, do you know what a Reynolds number is? A Reynolds number is a numerical measure of turbulence. It's a numerical measure of sound and turbulence. You see, the narrower the vessel, although the flow is down, the flow that does happen happens faster. The flow is down, but it's faster, and since it's faster, it's more turbulent. Well, how come isn't that net equal? The flow went down, but the speed went up, then it's equal. Actually, because it's not equal. The flow goes down, and the velocity goes up, so that's equal, Conrad? No, because the flow goes up faster. Speed of that flow, the velocity goes up more than the flow goes down. The flow goes down, but the velocity goes upper. And that's why it's faster. You see, what ends up happening in bruits is that the flow goes down, but it happens faster. Bruits of the renal artery, narrowing. And when the diagnosis, when the bruits, what is it? What is it? It's renal artery stenosis. The most accurate test of all vascular lesions is angiogram. And the therapy for narrowed things, in this case is dilation. But how the dilation? How to dilate it? So bruits of the renal artery have a high-pitched sound at the flanks and goes into the abdominal walls, because back in here is where your renal arteries are. The bruits of renal artery mean renal artery stenosis. They mean renal artery stenosis, and they're very specific. The problem is that renal artery stenosis can easily be present without a bruit, so the presence of a bruit is highly specific. The presence of a bruit is highly specific. And that's why it means renal artery stenosis. But renal artery stenosis, you see, the problem is that the bruit is not there half the time. So the most accurate test of all vascular structures is an angiogram, okay, and therefore the therapy is angioplasty, balloon angioplasty. The same way for mitral stenosis, it's valvuloplasty with a balloon. Angioplasty and stenting it. Oh, which one? We got a narrow one, we got a normal one, we got a narrow one, we got a normal one. Yes, we do. And they see what happens is that when you have that plaque building up there, you put a catheter in there and you balloon it. Take a catheter, put it into the renal artery, and pop it open with a balloon. You have a narrowing over there. You see that narrowing? And that narrowing has to be ballooned with a stent. That stent is placed, you get a balloon in there, and you put a stent in there to prevent it from restenosing. Without a stent, these blood vessels tend to restenose, and that's why you do this in coronary arteries with a stent, and you do it in renal arteries, and you coat the stent. You coat the stent with something that prevents restenosis, things that inhibit lymphocytes. So a Reynolds number is a measure of turbulence. Oh my God. Oh, that was frightening. It looked like mathematics. Man, don't scare me with that physics. Measure of turbulence, velocity, density. Oh my goodness. This is scary. Okay, they see diameter. Diameter means diameter of the tube. Velocity, the faster something goes, the faster something goes. The faster it goes, the more the turbulence. And the greater the diameter, the more the turbulence. The greater the diameter, the more the turbulence. Now, the more the viscosity, the less the turbulence. Viscosity goes up, turbulence goes down, because potato rivers flow with less turbulence. Mashed potato rivers flow with less turbulence than water rivers. Chocolate rivers flow with less turbulence than water rivers because there's more viscosity. Now, here's the thing that's said, well, flow goes down, how come turbulence goes up? And that is because the velocity is going up with the power of a square. As the surface area goes down, the velocity goes up with the power of the square. Inverted. The velocity is 1 over the surface area. 1 over the surface area, and the surface area is pi r squared. So therefore, as surface area goes down, velocity goes up much more, because velocity goes up to the power of the square, and that's why Reynolds number says the more narrow blood vessel, you're going to have a bruit. The more narrow the aorta, the more you're going to have a murmur. The more narrow the mitral valve, the more you're going to have a murmur. The flow goes down. Next one, Canon A waves. Canon A waves are where? A waves in the neck. Canon A waves are in the neck, and they're described. What are you thinking about when they're described? They're a sign of? They're a sign of the atrium contracting against a closed tricuspid valve. They're the sign of the atrium contracting against a closed tricuspid valve, and blood bounces backwards up. Blood bounces backwards up into the neck veins. Blood bounces backwards up into the neck veins, and the most accurate test is looking at an EKG. Canon A waves is a giant pulsation in the neck veins, and it's caused when the atrium contracts and the blood goes forward, but instead of the blood going forward into the ventricle, the blood bounces backwards up into the neck veins. The blood bounces backwards, so Canon A waves is caused by atrial systole against a closed tricuspid valve. It's caused by atrial systole caused by atrial systole against a closed tricuspid valve, and it makes it go up like a cannon shot up into the neck veins. Canon A waves. Now, if the case describes bradycardia, this is third degree V block. This is where the atrium and the ventricle are out of dissociation. They're dissociating. And the atrium's beating like this, and the ventricle's beating like this. And the atrium's beating like this, and the ventricle's beating like this. And it's like, you're beating like this, I'm beating like this, you're beating like this, I'm beating like this. They're dissociated. So the atrium is contracting against a closed tricuspid valve, and the blood is bouncing backwards up into the neck veins. The most accurate test is an EKG. So the reason that we have these physical findings cards put together like this in one group is because these are things that when you see patients, they're just not present a lot of the time. A lot of them, like head bobbing, Demusset's sign, de Rosier's sign, Quinky Pulse in the fingernails, these are in fact largely very 19th century descriptions. Truly, they're over 100 years old because cardiothoracic surgery is a pretty well-formed specialty for more than half a century. So most of them would be prior to 1950 because or a place where you can't get operated on. Because these things like head bobbing and Traub's sign, de Rosier's sign, even Canon A waves like this, they're signs of when you didn't just do cardiothoracic surgery and pop the valve out. But you're going to have to dissociate in your brain the part of your brain that says, oh, this is just a bunch of BS, I don't need to know this, this is just ridiculous, versus, no, you are expected to know it, period. I'm sorry, you just have to know. Canon A waves are atrial systole against the closed tricuspid valve. You do an EKG, that's the, okay, and here we are looking at them. Ready? Wow, disgusting, isn't it? Oh my God, that's so creepy. Opens the neck veins. Ooh, ah! Imagine what it's like to be him. And they're like, why don't you put a pacemaker in the person and stop the third gravy block? Well, why don't you give atropine and speed up the heart rate? Oh, but then who would the medical students have to examine? Next one, let's see. This is, what do you see? What's the difference? What's the difference between saying a noise and a bruit? What's the difference between the noise and the bruit? Well, everything is sexier in French. It's the bruit and the carotid artery. And when the bruit is in the stem, you're thinking of carotid artery stenosis, the most accurate test. See how we're repeating? It's a vascular structure, so angiogram is the most accurate test. A bruit is heard with the bell over the carotids, and you should not hear anything. There should be no sound. In other words, there should be no sound of left ventricular ejection. There should be no sound of the renal arteries filling. There should be no sound in the carotids. So any sound in the carotids is abnormal. How come you can have a murmur or a bruit there if the flow is down? And the answer is because it speeds up. The most accurate test is either duplex ultrasonogram and sometimes an actual angiogram. Now, we don't have to actually do an angiogram with a catheter too much anymore for anybody. That's sort of passé. In other words, putting a catheter in you and injecting contrast that kills your kidneys is not needed because duplex ultrasonogram is the sonar that was used to look for Nazi submarines in the Second World War. And now we adapt that. In the heart, we call it echocardiogram, and in these vascular structures, we call it duplex ultrasound. And you don't need the angiogram to see the narrowings. Remember, flow down, but speed up to the power of the square. Oh, look at these big legs. Ooh, why is that leg much bigger? Well, one leg is bigger. What is the diagnosis? The test and the therapy. Now, this is a Conrad Fisherism. You see, when we look at these questions like this is the way I want you to study. I want you to study by saying, you don't know which question you're going to get. You don't know, are you going to get asked, what's the diagnosis? Well, this is a DVT. What is the test? Well, duplex sonogram. Oh, what is the therapy? And the answer is heparin, warfarin, heparin, dabigatran, rivaroxaban. You see, when you study this way, you don't know what question you're going to be asked, so we're going to go through all these, and we're going to speed up the velocity because we can. And we're going to speed up the velocity to say, time to say, give us all the questions. Why ask for one miracle? Ask for all of them. Here's a deep venous thrombosis. The duplex ultrasonogram is the most accurate test, and what to say, it's usually the only one necessary. Venography is nearly never necessary to put a catheter in there and do a venogram. Almost never necessary, and we treat it by using heparin. We can use low molecular weight heparin. IV heparin has the same efficacy, so there's no reason to use IV heparin, or you can just use oral rivaroxaban without any heparin, and just bang, that's just as good, and you don't need to monitor the INR like you do for warfarin. You just give the rivaroxaban without the INR. Next card. Now, the displaced point of maximum impulse. There's a cardiac finding. The point of maximum impulse should be down there just past the nipple. And when it's displaced and pushed over to the side, it means it's pushed over to the side. And what does it mean when it's pushed over to the side? It's an anatomy question. Now let's look at some anatomy, because the displaced point of maximum impulse means my left ventricle is displaced laterally. Laterally, something you feel, point of maximum impulse. You feel it as the heart hits the chest. You feel it. It's a palpatory sign. It's a palpatory sign of cardiomegaly. And what we do is we use it to say that you have left ventricular hypertrophy, and we use it to test your knowledge of anatomy. Displaced point of maximum impulse, I feel it in a different spot. Right ventricular hypertrophy displaces the PMI to the right. Left ventricular hypertrophy displaces it to the left. Wow, it's a genius move, right? Right displaces right, left displaces left. And here's the sign. Wow, oh my God, oh my heart. For I have understood the large hearts of heroes, says Walt Whitman. Yes, here's this big hypertrophic heart. This is a very huge, thick wall, and this is what gives the displaced point of maximum impulse, because this big displacement is trying to say, I understand cardiac anatomy. The right ventricle is usually much thinner because the pressure in the lungs is lower. The right ventricle is much thinner because the pressure in the lungs is lower. The left ventricle is much thicker because the pressure, the systemic pressure, is much greater. Hypertrophies displace the point of maximum impulse. Let's hear it. So, what do we have here? The S2 is normally comprised of A2, aortic heart sound changing, and a P2, pulmonic sound. A2, aortic sound, P2, pulmonic sound. And normally there's a little bit of variation. There's a little bit of variation that when you inhale, it splits it. And when you exhale, it's less split. But the aortic valve generally closes first. Why does the aortic valve close first? Because the pressure in the aorta is greater. P2 is delayed with inspiration because of increased venous return to the heart. When you inhale, not only does air come into the chest, but more blood comes into the chest. When you inhale, there's not only does more air come into the chest, more blood comes into the chest, and that's how you'll be able to determine that it should normally split because of increased venous return. So there's normally no respiration there. Normally when there's a fixed split, when there's no variation by respiration in S2, this fixed split, this fixed splitting is caused, fixed splitting, no respiratory variation, is atrial septal defect. Fixed splitting is atrial septal defect, and generally speaking, anything that widens the split, that delays the P2, pulmonic stenosis, pulmonary hypertension. Delay P2, pulmonary hypertension. Right bundle branch block. Delays right-sided emptying, delays right-sided closing. Widen the split, delayed emptying, delayed closing. Pulmonary hypertension, pulmonic stenosis, right bundle branch block. Delayed emptying of the right side, delayed closing of the right side. Delayed emptying, delayed closing, splits it wider.